Hello, my name is Dr. Lisa Newman. I'm a surgical breast oncologist, and it's my very great honor to serve as Chief of Breast Surgery and of the Interdisciplinary Breast Program for Weill Cornell Medicine and the New York Presbyterian Hospital Network. Dealing with a new breast cancer diagnosis is a terrifying experience. As healthcare providers, we can only begin to imagine the complex fears and stresses that can so easily overwhelm our patients. We put together this video because we believe that the first step in overcoming these multiple anxieties is to be empowered with information regarding the diagnosis. One of the most gratifying aspects of my job as a breast cancer specialist is that I can inform my patients that with proper treatment, the high majority of breast cancer patients will continue to enjoy a full, productive, and healthy life. Going through that treatment, however, is not necessarily easy. But thanks to the wonderful advances that we've made in breast cancer research over the past several decades, we can usually offer patients a variety of different treatment options, and we can usually deliver those therapies with fewer side effects. One of the important lessons that we've learned about breast cancer through this research is that breast cancer is not just one single disease. Breast cancer is actually comprised of a variety of different subtypes and patterns. Regardless of the breast cancer pattern or subtype, however, it's our job as breast cancer specialists to put together treatment plans that will not only address the disease within the cancerous breast itself, but we also have to address the microscopic breast cancer cells that might be hiding in other parts of the body, such as the liver, the lungs, or the bones. This team effort is what we call multidisciplinary management of breast cancer. Members of this multidisciplinary team involve radiologists, pathologists, medical oncologists, surgeons, radiation oncologists, nurse navigators, nurse oncologists, and geneticists, as well as several other types of specialists. At Weill Cornell Medicine and throughout the New York Presbyterian Hospital Network, our team of dedicated breast specialists meets on a regular basis in meetings that we call our breast tumor board meetings. And in these meetings, we discuss each and every case so that we can put our heads together and come up with the best treatment options that are appropriate for each individual patient, and then monitor those treatment plans as they proceed. Over the next few minutes in this video, I'll talk to you about some of the basic concepts that we discuss in those tumor board meetings when we come up with appropriate treatment plans, and I'll focus on giving you an overview of some of the surgical strategies that we review for our breast cancer patients. Controlling the disease in the breast for a breast cancer patient almost always involves some surgery. Now, the goal of that surgical plan is to remove or to eradicate the diseased area in the breast, the obvious area of disease in the breast that led to the biopsy and the diagnosis, but we also have to address microscopic breast cancer cells that might be hiding in otherwise normal-appearing breast tissue. Mastectomy is actually the oldest form of treatment for breast cancer, and when we perform a mastectomy and remove the entire breast, we're taking care of both of those first two principles in one fell swoop. The alternative to mastectomy surgery, however, is what we call breast conserving or breast saving surgery. With breast conservation, we perform a lumpectomy to focus on removing the diseased tumor in the breast, and then we usually rely upon radiation treatments to kill any of the microscopic cancer cells hiding in the normal remaining breast. Survival from breast cancer is actually exactly the same regardless of whether the patient chooses the mastectomy surgery or the breast conserving surgery. The reason why survival is the same with these two very different surgical approaches is because of the fact that the way breast cancer can be potentially life-threatening is by the breast cancer cells that can damage other parts of the body, such as the liver, lungs, or the bones. Many women with breast cancer, even if they're diagnosed with early-stage disease, might have microscopic breast cancer cells hiding in other organs, such as the liver, the lungs, bones, or the brain. And this is what we call micrometastatic disease. To kill micrometastatic disease, we have to deliver medical treatments for breast cancer. Medical treatments that get absorbed through the bloodstream and circulate throughout the body, and many of these medical treatments are extremely effective at killing the micrometastatic disease hiding in other organs. Some forms of medical or systemic therapy for breast cancer involves giving pills. Other forms of medical treatments for breast cancer are given through intravenous lines, such as chemotherapy. Some patients will require both pill forms and chemotherapy. We work together as a team to decide which patient needs chemotherapy and/or these pills by looking at a number of different clues. Some clues are related to the size and extent of the cancer. Other clues are related to the microscopic pattern of the cancer. In yet other patients, we might need to perform special sophisticated genetic profiling of the tumor to decide which medical treatments are necessary. One of the very powerful clues that helps us to identify which patients need chemotherapy is through evaluating the lymph nodes or the glands of the underarm area, also called the axilla. Most patients with breast cancer will therefore require a surgical procedure to evaluate these lymph nodes, and if it turns out that there are cancer cells hiding in the lymph nodes, that's a pretty powerful clue that the patient might also have microscopic cancer cells hiding in other organs that requires chemotherapy for management. Evaluating these lymph nodes is therefore important regardless of whether patients choose the lumpectomy, the breast-conserving surgery, or the mastectomy surgery. Similarly, decisions regarding which patients need chemotherapy will also be the same regardless of whether the patient chooses the lumpectomy, the breast-conserving surgery approach, or the mastectomy surgical approach. So a few more comments that are important to add regarding the choice between lumpectomy and mastectomy surgery. There are some patients who are better served by a mastectomy compared to lumpectomy. We evaluate the clinical breast exam and the baseline mammogram, as well as sometimes other breast images, to determine whether or not a lumpectomy is appropriate. Some patients who have multiple tumors in the breast require a mastectomy. Some patients that have diffuse problems on their mammogram or other breast imaging studies may be triaged toward a mastectomy operation. There are some patients where we perform a lumpectomy, but we are not successful, and the lumpectomy margins demonstrate that there are cancer cells close to the surfaces of the lumpectomy specimen. If the lumpectomy margins are not negative, then we do need to recommend that the patient undergo additional surgery, either in the form of a follow-up lumpectomy or in the form of a mastectomy. There are some patients that have contraindications or medical problems such that they are unable to receive radiation therapy, and this might also be an indication to recommend a mastectomy. Sometimes we have to counsel patients regarding the amount of asymmetry or disfigurement that they might end up with if they have a lumpectomy and radiation treatments can indeed cause some shrinkage of the breast. When it comes to some of these cosmetic issues, however, the patient has to decide whether or not they are comfortable with the likely appearance of their breast, and that may or may not factor into the decision regarding mastectomy. There are some patients who, for completely personal individual reasons, may voice a preference for a mastectomy or even a double mastectomy. Some patients who have a single tumor in one breast might opt to undergo a mastectomy or a double mastectomy simply because they want to avoid radiation or because they want to reduce the chances of ever having to undergo future breast biopsy or breast cancer treatment experiences in the breast itself. Regardless of the reason for pursuing mastectomy surgery, whenever a mastectomy is performed, we do always want the patients to take advantage of any breast reconstruction options that are available. And most patients will indeed be candidates to undergo breast reconstruction by our plastic surgery specialists. This breast reconstruction can be performed at the same time as the mastectomy, which is what we call immediate reconstruction. For a variety of reasons, some patients may choose to undergo reconstruction in a delayed fashion, either months or years after the mastectomy surgery has been performed. Next, you'll be hearing from several of my wonderful colleagues discussing their various areas of expertise in breast cancer management. Please know, however, that even though you're listening to us as individuals in the course of this video, and even though you'll be meeting with several individual specialists throughout your clinical care, all of us at the Weill Cornell Medicine program and throughout the New York Presbyterian Hospital network are continuing to meet as a team in our tumor board meetings to discuss your individual case, as well as to monitor your treatment outcomes to make sure that you take full advantage of all of the resources that we have to offer here at Weill Cornell Medicine and throughout the New York Presbyterian Hospital Network. And we want to make sure that you take full advantage of all the wonderful advances that we've made in breast cancer research over the years.
Hi, I'm Rasha Simmons. I am a breast surgeon here at Weill Cornell. I've been doing breast surgery here for 25 years. And I'm here today to talk to you about an option for many of our patients, which is nipple-sparing, skin-sparing mastectomy and reconstruction. Why would a woman have a mastectomy? So about 80% of our breast cancer patients are candidates to have a lumpectomy. But there are some patients who either need to have a mastectomy or desire to have a mastectomy. Some of those reasons might be that the patient has a very large cancer in her breast, would not really be amenable for lumpectomy. Or she may have multiple small cancers within the breast that also really not lend itself safely to a lumpectomy. Additionally, some patients have a very high risk of developing breast cancer in their lifetime. Those patients would include those that have either what's called a BRCA mutation or a strong family history of breast cancer, or patients that have had other predisposing risks such as radiation to their chest as a teenager for diseases like lymphoma. These patients are at a very high risk of developing breast cancer and may choose to electively have mastectomies to prevent having breast cancer in the future. Another situation that arises is in patients who have breast cancer on one side and either desire or need to have a mastectomy, and ask the question, what about the other breast? Should I have a mastectomy on the other contralateral breast? So what I tell patients is that we don't assume they have breast cancer in the other breast right now. They could develop breast cancer in the opposite breast at some point in their lifetime, and much of that risk level depends upon family history and their age and other factors that would tell us how likely it was they would develop a contralateral or opposite side breast cancer. But many women choose to have an opposite side mastectomy for the following reasons. Sometimes they say to me, I just want peace of mind. I just want to know that I don't have to think about breast cancer ever again. And I don't want to have to keep getting imaging. I just want to put it behind me. Other patients may make that decision just purely because of cosmetic symmetry. It may be a significant advantage to them, if they have in particular large breasts, to be symmetrical with the reconstruction after their mastectomy. Patients often ask me, what types of mastectomies are there? There are several different kinds of mastectomies. And which type is best for a patient really depends upon the kind of cancer she has, the location of her cancer, and really the recommendations of her surgeon. Certainly many patients are able to have what's called a skin-sparing mastectomy. That means saving all the skin of the breast, but taking the nipple and the areola complex. This would typically be a patient that had an area that was of concern near the nipple, where the surgeon felt it was safer to remove the nipple, but to save all the skin of the breast. Now, many patients are actually a candidate to have what's called nipple-sparing mastectomy. And in these patients, what typically will happen is the surgeon will make an incision, often down in the crease of the breast, very cosmetic incision. We all have a wrinkle there anyway. And then through that incision, the surgeon is able to remove all the breast tissue, but save the skin and save the nipple and the areola. So what is the advantage of saving the skin or saving the nipple in a mastectomy? The obvious advantage is that it is a much more natural appearing reconstruction. So when the breast tissue is removed, particularly with saving all the skin and the nipple, and the plastic surgeon then performs a reconstruction, it's a very natural appearing breast. Many patients honestly tell me that they can't even tell that they had a mastectomy. It's a really beautiful reconstruction and a wonderful option for many of our patients. Patients often ask me, is there any risk in saving the nipple areola in the course of a mastectomy and reconstruction? What I tell them is that there have been many studies, including many of our own studies, looking at that very question. And what we found is that in appropriately selected patients, there is not any increased risk in saving the nipple areola compared to taking it. The risk of having a recurrence in the nipple of the areola is really no different than any of the other skin in the breast. Now, having said that, what I always do is I remove a tiny piece of tissue from right behind the nipple and the areola. If that turns out to be completely negative, as that usually does in appropriately selected patients, then there is no increased oncologic risk in saving the nipple in the course of a mastectomy. So how does the breast surgeon work with the plastic surgeon in planning the reconstruction and the incisions for the mastectomy? I work on a regular basis with excellent reconstructive surgeons who are very concerned with, of course, treating the cancer, but as well making sure that the woman looks as beautiful as possible and as natural as possible with the reconstruction after the mastectomy. There are two main ways to have reconstruction. One is implant reconstruction, and one is moving fat from somewhere elsewhere in the body, usually from the abdomen, the lower abdomen. And the plastic surgeon will have that conversation with the patient, discuss at length which reconstructive option is better for her. I really do my surgery pretty much the same, whichever the reconstruction options are best for the patient. I do care about the incisions, as of course does the plastic surgeon. The typical incision that I make for a mastectomy is in the crease of the breast, which is a place that women have a natural wrinkle anyway. So to make an incision down in the crease of the breast, followed by a mastectomy, removing all the breast tissue, saving the skin, saving the nipple, and then having the plastic surgeon come in and reconstruct what I've removed is a really beautiful, cosmetically desirable way to do reconstruction on these patients.
Hello, my name is Jennifer Marty. I'm a breast surgeon on staff here at Weill Cornell Medicine, and today I'm going to talk to you about axillary lymph node surgery in patients with breast cancer. What are axillary lymph nodes and where are they located? Axillary lymph nodes are small bean-shaped structures that are located in the axilla or the underarm. They're an important part of the lymphatic system. Their function is to drain fluid from the arm and the breast and also to help fight off infection. Why is it necessary to perform surgery on the axillary lymph nodes in breast cancer? Performing surgery on the axillary lymph nodes is commonly performed in patients with breast cancer. The reason why this is done is when a patient has breast cancer, if it spreads to other sites, one of the first places it will spread is the lymph nodes of the underarm. So at the time of surgery, either lumpectomy or mastectomy, generally speaking, we begin with a sentinel lymph node biopsy, and this is to sample the lymph node to make sure cancer has not spread to the lymph node. This information is important to us for staging, for treatment planning, and for prognosis. What are different ways that the axillary lymph nodes can be evaluated? We can assess the status of lymph nodes in various ways. We begin with physical examination, looking for firm or enlarged lymph nodes. We also look to the mammogram or ultrasound to see if any abnormal lymph nodes are visualized. And then we can assess it with tissue in various ways. We can either perform an ultrasound-guided needle biopsy, or at the time of surgery, we can remove some lymph nodes to assess for the presence of cancer within the lymph node. What is a sentinel lymph node biopsy and how is it performed? A sentinel lymph node biopsy is a procedure that we commonly perform at the time of lumpectomy or mastectomy. This procedure is a sampling of some of the lymph nodes of the underarm to assess if cancer has spread to the lymph nodes. In order to identify the sentinel lymph node, the patient receives an injection in the breast, often a radioactive liquid, and possibly a blue dye. And during the time of surgery, we look for nodes that contain the radioactive tracer or that are blue, and these are removed and sent to the pathologist to look under the microscope for signs of cancer cells within the lymph node. What is an axillary lymph node dissection and how is it performed? An axillary lymph node dissection is a procedure to remove all of the nodal tissue of the underarm or the axilla. It's performed in the outpatient setting. The surgery is a same-day procedure. We make an incision in the underarm. We remove all the fatty and nodal tissue of the underarm or axilla, and we place a drain. Patients go home, the drain is there to help drain lymphatic fluid, and we pull the drain in the office a few days later. What are the risks of axillary lymph node surgery? There are a few risks to axillary lymph node surgery. In general, when we sample just a few lymph nodes, as we do with the sentinel lymph node biopsy, that is very well tolerated and the risks are very rare. Some patients, however, may experience an allergic reaction to the blue dye that might be injected to help identify the sentinel lymph node. The risk of permanent arm swelling is infrequent, occurring in roughly 5% of patients. Some patients may require removal of all the nodal tissue of the underarm. This is called an axillary lymph node dissection. In that procedure, the risk of permanent arm swelling or lymphedema is estimated at 20%. Some patients will experience numbness of the inner arm that can be permanent, and some shoulder and arm weakness, which is almost always temporary.
Hi, I'm Dr. Tessa Sigler. I'm a medical oncologist at Weill Cornell who specializes in breast cancer. I'm here today to give you a brief overview of systemic therapy to treat breast cancer. What is systemic therapy for breast cancer, and why is it necessary? The big worry about breast cancer, no matter how big or how small, is there's always a chance that even before a woman knows she has breast cancer, that there might be some microscopic cells too small to see with the microscope, with CAT scans, with mammograms, that might have escaped and could be somewhere in a woman's body. And over the next many years to come, those cells can grow back as breast cancer, most worrisomely in other parts of the body. The reason to see a medical oncologist is to discuss therapies, prevention therapies, to decrease the risk that the breast cancer can come back in the future. Systemic or medical therapy for breast cancer is prevention treatments designed to decrease the risk of the breast cancer coming back in the future. The options for systemic therapy include chemotherapy, anti-estrogen therapy, and sometimes antibody therapies. As medical oncologists, no two breast cancers are the same, and we treat every breast cancer differently, depending on the unique characteristics of each woman's breast cancer. Breast cancer falls into three main categories: estrogen receptor positive breast cancer, HER2 overexpressing breast cancer, and breast cancer that expresses neither estrogen, progesterone, or HER2, often referred to as triple-negative breast cancer. To decide which prevention therapies are necessary, we take into account the pathologic features of a woman's breast cancer, the size, the grade, the number of lymph nodes, and we also look very carefully at the receptor expression profile, the estrogen receptor, the progesterone receptor, and the HER2. Based on these features, we decide whether chemotherapy might be necessary, whether antibody therapy is necessary, and whether anti-estrogen therapy is necessary. What is endocrine therapy, and how is it given? Endocrine therapy, sometimes called hormonal therapy, is actually anti-estrogen therapy that's used to treat breast cancer that's estrogen and/or progesterone receptor positive. Endocrine therapy most commonly exists in pill form, either tamoxifen or a group of drugs called an aromatase inhibitor. What is chemotherapy, and how is it given? Certain breast cancers require chemotherapy. Chemotherapy is a class of anti-cancer medication that's almost always given intravenously or through an IV. What is targeted therapy for breast cancer? To treat breast cancer that overexpresses HER2, we often use targeted therapies or antibody treatments in addition to chemotherapy. These antibody therapies specifically target the HER2 receptor and make the chemotherapy much more effective for this type of breast cancer. How does a medical oncologist decide which systemic therapies are necessary? Each breast cancer is unique, and the specific characteristics of each breast cancer have to be carefully taken into account in order to individualize a treatment plan. We look very carefully at the pathologic features of the tumor, including its size, its grade, whether or not lymph nodes are involved. We also carefully examine the receptor profile, whether the tumor expresses the estrogen or the progesterone receptor, and whether it overexpresses the HER2 protein. The combination of all these factors help us to decide whether to recommend chemotherapy with or without antibody therapy, and whether or not to recommend hormonal therapy or anti-estrogen therapy. What are the side effects of therapies, and how can they be minimized? Common side effects of endocrine therapy include hot flashes, night sweats, joint pains. I always tell my patients that everyone's different. Some women experience minimal side effects, while others experience quite a lot of side effects, and in those cases, we have lots of tricks we can use to make women feel better, and often we have to change or alter medications. Hair loss is often the most dreaded side effect associated with several chemotherapy programs. Some women undergoing chemotherapy might be a candidate for scalp cooling, which is a technique that can be used to minimize the hair loss associated with chemotherapy.
Hi, I'm Silvia Formenti. I'm the Chair of Radiation Oncology at Weill Cornell, and I will talk to you about breast radiotherapy. What is radiation therapy? Radiation therapy is a form of cancer treatment that uses ionizing radiation. The radiation is produced by a big machine that is capable to focus the radiation beam to target exactly the tumor and the tumor microenvironment. By doing so, radiation is capable to kill tumor cells. Is radiation always necessary after a lumpectomy? Radiation therapy is always necessary after a lumpectomy. Many studies have shown that if after a lumpectomy the woman undergoes radiation therapy, her odds of recurring are equal to a woman who would have undergone a mastectomy, the removal of the entire breast. Because of that, radiation substitutes for a mastectomy when combined with radiotherapy. When is radiation necessary after a mastectomy? There are cases when, after a mastectomy, women will be advised to undergo radiotherapy, sometimes after mastectomy and reconstruction of the breast. The reason for this advice is because the disease was found to be a little bit more advanced than what was foreseen before. In those cases, adding radiation conveys advantages not only in terms of preventing the disease from coming back in the breast, but also enhances the chance of surviving breast cancer. How is radiation delivered, and most importantly, how long does it take? Radiation therapy is traditionally delivered over several weeks. We are fortunate to be able now to reduce the number of weeks to only 3, and in some patients, in some cases, can even be limited to just 1 week. It depends on the extent of the tumor and the characteristic of the tumor found at segmental mastectomy or at lumpectomy. Radiation is delivered in a very precise fashion, following a plan developed with our physicists and tailored around the exact shape of the patient's body. We have learned that for most women, it's better to be positioned lying on their stomach. And you can see in the image how that is particularly advantageous in making sure that the breast moves away from the chest wall. It is then much easier to target with a radiation beam while avoiding completely the heart and the lung. The heart is naturally close to the chest wall. And because of that, as you can see in this image, if a woman is treated lying on her back, inevitably part of the heart will be in the radiation field, and that could generate long-term damage to the heart. However, for most women, lying on their stomach prevents this risk and makes sure that we target adequately the breast, the tumor cavity, and completely avoid heart and lung. When is radiation therapy given to other parts of the body? Commonly, radiation therapy can target any part of the body and can do so in a very safe and controlled fashion. In the setting of breast cancer, radiation therapy often targets beyond the breast the draining lymph nodes. Not all patients have the indication for treating the lymph nodes. If you are one of those patients, your doctor will discuss with you the rationale for doing so. In some patients, the disease comes back. When the disease comes back, the management is again through many disciplines, with chemotherapy, with hormonal therapy for some patients, and sometimes with radiotherapy. Radiotherapy can focus the beam to target expressions or metastases of breast cancer in the rest of the body, whether it's in the bones, in the lung, in the liver, in the brain. At each of these sites, radiotherapy is very successful at eliminating the cancer. What are the side effects of radiotherapy? Some side effects of radiation therapy are changes in the color of the breast, or a little bit of inflammation of the skin on the breast. In general, side effects of radiotherapy depend on the organ targeted by the radiotherapy. So if the radiotherapy is targeting the breast, they will affect the breast. They will not result on losing your hair or any other side effects elsewhere in the body. We discussed before how by putting patients on their stomach on a prone position, one can avoid including in the radiation field, by radiation beam, lung or heart. So the side effects will be only limited to the breast, will be very reversible and generally minimal for most patients.
Hi, I'm Dr. Arleo from Cornell Radiology, where I specialize in women's imaging. We get a lot of questions from patients who have had breast cancer and have had breast conservation treatment about how often afterwards they should get breast imaging. I'm going to try to answer some of those questions now. As faculty of Weill Cornell, I'm required to disclose to you that I'm editor-in-chief of the radiology journal Clinical Imaging. In patients where breast cancer was associated with calcifications, after lumpectomy, diagnostic mammogram with magnification views should be considered to exclude residual calcifications prior to beginning radiation therapy. Otherwise, bilateral diagnostic mammogram 1 year from the date of the mammogram when the cancer was diagnosed should be obtained. Routine 6-month follow-up imaging is no longer recommended. Diagnostic mammography will continue 2 years post-treatment, and then the patient should return to screening mammography the 3rd year post-lumpectomy. By request, all of our patients can continue to have their screening mammogram read the same day by one of our dedicated breast imagers so they can still receive their results on the same day. Additionally, annual breast MRI should be considered for patients with a personal history of breast cancer who have dense breasts and were diagnosed before age 50. For more information or a consultation with a radiologist, please contact our dedicated consultation service. Thank you.
Hi, my name is Susan Loeb-Zeitlin, and I am an assistant professor of clinical obstetrics and gynecology here at Weill Cornell Medicine, New York Presbyterian Hospital. I am honored to be part of the multidisciplinary breast cancer treatment group representing the Department of Obstetrics and Gynecology. Today, I'm here to discuss some issues regarding fertility and sexual health as they relate to your breast cancer treatment. How can breast cancer treatments affect fertility and future childbearing? Breast cancer treatments, especially chemotherapy, may cause a decline in ovarian function. Additionally, after initial therapy, it's often recommended that a woman take hormonal therapy for 5 more years. This may cause an age-related decrease in ovarian reserve. It is very important to avoid pregnancy during treatment. Some studies have shown that it may be possible to interrupt hormonal therapy for a pregnancy, but a woman should not conceive while taking hormonal therapy. Fortunately, we are able to do egg or embryo preservation before initiating chemotherapy, so that at a safe interval, even if the ovaries are no longer functioning, a woman may carry a pregnancy. We are able to refer you to our reproductive endocrinology department for a consultation and treatment. Can patients become pregnant after breast cancer treatment? Once again, it's very important not to conceive during the treatment for breast cancer and for varying intervals after the completion of treatment. The good news is that pregnancy does not appear to increase the risk of recurrence for breast cancer, and the medications used for the treatment of breast cancer do not appear to have long-term teratogenic effects. For those women diagnosed with breast cancer during pregnancy, we work with the high-risk obstetricians to determine the best timing during pregnancy to initiate treatment and also the appropriate timing for delivery. The breast oncology team has explained that oral contraceptives and hormone replacement therapy should be avoided in breast cancer patients. What are some of the safe and reliable alternatives for birth control or to minimize hot flashes and night sweats after menopause? For contraception, there are safe, reliable, non-hormonal methods, including condoms, the copper IUD, and the diaphragm. These are the preferable modes of contraception. In individual circumstances, the progesterone-containing IUD may be appropriate and may protect against some of the tamoxifen effects on the uterus. For hot flashes, There are many non-hormonal options. Paxil, or paroxetine, is in the class of drugs called selective serotonin reuptake inhibitors, also known as SSRIs. This has an FDA-approved label for the treatment of menopausal hot flashes. There are other SSRI or SNRI drugs which also help hot flashes. Many of these need to be avoided in women taking tamoxifen, but some interfere less with tamoxifen and may be considered in the appropriate circumstances. Gabapentin, an anti-epileptic medicine, also has been shown to help hot flashes and night sweats and is often well tolerated. There are some other treatments for hot flashes that work for some people, including acupuncture, cognitive behavior therapy, meditation, weight loss, vitamin E, and avoiding triggers such as spicy foods or anxiety-provoking or stressful situations. Caution should be taken when using herbal supplements and should only be done in consultation with your physician. Regarding other menopausal symptoms, each person's situation should be addressed individually. The diagnosis of breast cancer does not need to affect intimacy, but it is not unusual for breast cancer patients to find sex more painful and less enjoyable. Additionally, many women are dealing with changes in their own body image or hormonally related changes. These are issues we can discuss in the office and, if necessary, make the appropriate referral to therapists. One of the main issues that women deal with is vaginal dryness. This can be treated with vaginal moisturizers and vaginal lubricants. These are available over the counter. There are many options available. Some people also find coconut oil helpful. We can talk about vaginal dilators that women can use as an exercise to help stretch the vagina. Depending on the treatments being given and the nature of the cancer, we can discuss using vaginal estrogens. This again is on an individual basis.
Hi, I'm Dr. Maida Pires. I am the cancer genetic counselor at the Weill Cornell New York Presbyterian Breast Clinic. Today, I will be talking about some of the important points that I always discuss with my patients about cancer genetic counseling related to breast cancer and how it relates to them. What does genetic testing comprise of, and what am I being tested for? The test comprises of drawing one small tube of blood today, and you'll be asked to sign consent for genetic testing. Although being tested is always voluntary, if patients have been referred to be tested, it means that we are at a greater concern that there could be a hereditary component that could have led to the patient's breast cancer diagnosis. And therefore, we want to make sure that we're not missing it, and patients are recommended to be tested. The panel or panels of tests that you'll be tested for will depend on what your breast surgeon feels is best for you. You can speak with your surgeon if you have any questions about this. What protections do patients have from genetic discrimination today if they are tested? There is a law called GINA that has been enacted since 2008 that provides patients with genetic discrimination protection so that they can be tested for their care. This law, as it stands today, says that for the most part, your work and your health insurance cannot discriminate against anyone due to a genetic finding or genetic predisposition. Today, this would be against the law. This means that although they may know about it, they are not allowed to act on it in any unfavorable way. For example, your job cannot demote you or your health insurance cannot increase your premium should they find out you were born with a predisposition to breast cancer by genetic testing. Although this law is a good thing for patients today, it does not yet cover other potential types of genetic discrimination, such as life insurance, long-term care, or disability. This does not mean that these other insurances will definitely act and discriminate based on a genetic test result, but it means that there's no law protecting patients at this time if they do. So what kind of results can one get in genetic testing for breast cancer and other cancers, and what does this mean for the patient? The three types of results are negative, positive, and uncertain. A negative result. Most women tested, even with a breast cancer diagnosis, will have a negative test result. It means that the lab did not identify any genetic predisposition in your test. In other words, no mutation or change in any of the genes being tested was found that is known to be associated with increased risk for breast and other cancers. A negative result does not mean, however, that one is not at risk for other cancers that may be in the family. Factors such as genetic causes not evaluated by this test, family history of cancers, and environmental factors may all play a role in still predisposing someone to cancer. Therefore, a negative result means patients should still go on being taken care of and screened given their personal and family history of cancers and risk factors. What about a positive result? This is the least common type of result, as only 5 to 10% of women have a mutation identified and reported in their lab report. And it means a mutation or a change in a gene being tested that is known to be associated with cancer risk was found and reported by the lab. Depending on what gene the mutation is identified, we will know what cancer risks are associated with being born with that mutation. Remember, a positive result does not mean you will get cancers associated with that mutation in that gene. Many factors go into why someone may be diagnosed with cancer. A positive result will impact a patient's care. It may add additional screenings, suggest surgical recommendations, and possibly provide additional options for medications for their care. A positive result has implications for the patient's family members. Children and siblings are at 50% chance of inheriting the same mutation, and therefore are recommended to be tested with the exception of children who are under the age of 18. With very few exceptions, the genes you're being tested for do not typically impact children's risk for cancer, and therefore, unless otherwise, they are not to be tested unless they are adults and can consent to this test. This, for the most part, means that you inherited this mutation from either your mom or your dad, and therefore relatives from both sides of the family should be notified unless we know which side of the family the mutation is coming from. The third type of result is uncertain. An uncertain result is very common in any genetic test, as we all have many differences in our genes, and we have not yet understood what every difference means in terms of cancer risk. 1 in 3 patients will get at least one uncertain in their test. Please do not be alarmed. We treat uncertain variants until we learn more about them as negative, as they should not impact your care at this time. Like a negative result, if you have any uncertain variants found, you still need to be taken care of based on your personal and your family history of cancer and risk factors. Like a negative test result, you should be retested in 3 to 4 years for the newer genes that will be identified associated with hereditary breast and other cancers to keep ruling out that no mutations would be identified in you, unless your personal and/or your family history of cancer changes significantly before that time, and you can discuss if retesting earlier is appropriate for you. How long do genetic test results take for me to know? And is there any cost associated with doing the test? The breast cancer stat panel that's ordered by your breast surgeon will be the fastest result possible. You may be called within about 2 weeks after drawing your blood, or sometimes a little earlier. There may be additional tests that your surgeon may order for you, but any additional testing results may be given much later in time, as these do not impact your immediate care for breast cancer. A copy of your health insurance is submitted to the lab that is running the genetic test, and it is the lab's billing department, not us, that will ask for the coverage of the test, and it will run by your insurance. There is no pre-authorization done for genetic testing. However, the lab will notify the patient directly if their insurance did not cover the cost of the test and ask the patient for the out-of-pocket cost. The cost out of pocket may vary by lab, and although it is possible that this number will change over time, we currently typically see at most $250 out of pocket in case a patient's insurance does not cover it. In case of financial hardship to pay for an out-of-pocket test, please ask us if there is any financial assistance form by the lab for you to fill out for a potential decrease in out-of-pocket cost. So who notifies patients of their genetic results, and what are the next steps? The nurse that works with your breast surgeon will call you with the results of the genetic test. You may request a copy of your result to your breast surgeon team after you've been called with your result, and a copy will also be scanned into your charts so that every clinician in your care at Weill Cornell, New York Presbyterian, will have access to it to best take care of you. You may be referred to me, the genetic counselor at the breast clinic, if your result comes back positive for a mutation that predisposes one to hereditary breast and ovarian cancer. Again, depending on your result, if negative, you go on about your care as usual and come back a few years later for update testing. If positive, you'll be referred to either me as the genetic counselor at the breast clinic or to another genetic specialist at Weill Cornell New York Presbyterian to discuss the result and know the next steps. If uncertain, you treat it like a negative for the time being and go on about your care as usual and come back years later for update testing.
Hi, I'm Dr. Ann Moore, Director of the Breast Cancer Survivorship Program here at Weill Cornell Medicine, New York Presbyterian Hospital. With 3.5 million women in this country having had breast cancer, we needed to develop a program to follow up on their care after their active treatment is over. So what does survivorship mean? Survivorship is a term given to us by the National Cancer Institute to describe the time when a woman or a man has completed their active treatment for cancer. They have finished their surgery, finished their radiation therapy and chemotherapy, if that's what's going to be given, and they're off on their own. We want them to feel comfortable, secure, and not lost in this period of transition. So when do I need to participate in survivorship care planning? Survivorship care planning came to be because we now have 3.5 million women in this country who have had breast cancer, and they are doing fine. The survivorship care plan is the first part of the program in which you are given a document summarizing the treatments that you've had, as well as a program of follow-up. When to do the mammogram, when to see the doctors, what medication side effects should you watch for, when should you call the doctor. The second part of survivorship care planning is an actual survivorship clinic, which comes in about 4 or 5 years after you have finished your active treatment. At this time, your oncologist will refer you to the survivorship clinic, where the nurses and doctors in the clinic will assume your oncology care. That will involve an annual visit, a review of how you're doing, watching for any cancer recurrence, and teaching and monitoring everything that goes into living a long and healthy life.
How has breast cancer treatment changed over time? Initially, when patients had a diagnosis of breast cancer, the person that was in charge of your care, and was the sole person in charge of your care, was your breast surgeon. Why was that? Because at that time, this is many years ago, of course, there really was no other therapy available. You saw the surgeon, you had this radical operation that was the best that could be given at the time, and you went on with your life. As time went on, it became clear that surgery was not the only answer to the best treatment possible. It became clear that chemotherapy, radiation therapy, these other modalities of treatment for breast cancer became very important. So then the question is, if they've become so important, how do you put all of these therapies together? And how do you get to the point where you have all these people who are talented in their respective fields working together? Hence was the evolution of the breast center. The idea of the breast center is that in one setting, you get a chance to have multiple specialties of talented individuals take care of you and put in their input. So maybe surgery is just one part of it. Chemotherapy could be another part. Radiation therapy. All of these people are able to sit in one place, discuss your therapy on a personalized level. So you get that personalized care. And that's the magic of having a breast center such as the Weill Cornell. Have breast cancer rates improved over time? Breast cancer survival rates have improved for a variety of reasons, but one of the reasons that people think is that the care of the breast cancer patient has changed because you have the input of many different disciplines. I think the fact of the matter is that it's certainly true that mammography, diagnostic imaging studies have gotten better. We're finding disease at an earlier stage. We're understanding the mechanism of how that normal cell becomes a breast cancer cell. This is the key to understanding and therefore the treatment and then therefore cure. We know so much more about this disease than we did in the past. And it's because we have a multidisciplinary group of people working together actively to try to come up with the best care possible. So when we look at survival rates, certainly they are improving. But But it's not only that the survival rates are improving, your quality of life survival is also improving. Over the last few years, it's become clear that as people are surviving longer, that there is a great deal of life ahead for all the patients. And we wanted to think of it as a normal life. And so where we talk about people survive this disease, here at Weill Cornell, what we've put together is a program where you thrive. And this is the idea of what a word that sounds a little funny, but it's called oncoplasty. Oncoplasty is a technique that was pioneered here at the Weill Cornell Breast Center. What does that mean? That means that essentially we look at you as a patient who has a bad problem. And that bad problem is that bad cancer that has taken over your life for a short period of time, we hope. And we can take care of that. There are surgical techniques that are there that are absolutely important to make sure that that tumor is removed properly. So they're called radical cancer techniques. So become radical for the surgical procedure to eradicate disease. However, there's another part to this. The other part is the realization that there's life after the breast cancer. What we have been able to do is incorporate plastic surgical techniques that put all the tissue back together again, so that when we're finished, there's a minimal amount of distortion or change in your physical appearance. It's very important because it gives you back your life. It gives you back the idea that you can be the same person you were before that breast cancer. The Breast Center at Weill Cornell exists because of the generous donation of Iris Cantor and her vision of putting together a multidisciplinary group of talented individuals. New York Presbyterian Hospital was involved in the very beginnings of our breast center, and as it evolved, it became clear that we had to offer things other people couldn't. You always have to ask the question, is this the best way to do something? Maybe there's a better way to do something. And if you don't ask that question, you will never, never move the field. Our individuals over the years who have been members of our breast center were those kind of people. They thought about different ways of doing the breast surgery. Did we have to do such radical incisions? No. Could we do smaller incisions? Could we remove less lymph nodes? Could we perhaps do more cosmetic mastectomies? All of these forward-thinking ideas distinguish our breast center from others in the region.
We hope that you have found this video helpful and educational. We also thank you for spending time with us and for entrusting us with any aspects of your care. Please do not hesitate to reach out to us if you have any questions or concerns. Here at Weill Cornell Medicine and throughout the New York Presbyterian Hospital Network, our breast oncology program specialists are here for you.